because the timing was for the pulmonary arteries, and they are the ones that had really good contrast opacification, and our aorta wasn't really well opacified. And also the acquisition, we were not able to capture the whole length of the aorta and its branches. For a CT aortogram, we expect to capture from above the aortic arch, and we go as far as the femoral arteries distally. And for this one, it was a CTPA, so we just ended like mid-abdominal aorta. So before we go to look into the images of the patient, I wanted us to go through this 3D volume rendered image of the thoracic aorta because it has a different part. I wanted us to orient ourselves so that we can relate very well when we are looking at the patient's images. So the thoracic aorta has different parts. We have 4 different parts. We have the aortic root, then we have the ascending aorta, the aortic arch, and the descending aorta. So the aortic root, it extends from just above the aortic valve, and it ends at the sinotubular junction where we see the connection between the aortic root and the ascending aorta. Then within the aortic root, we have these 2 bulges, which are sinus of Valsalva, and it's where the coronary arteries arise from. It's important that we know them because sometimes the dissection can actually extend up to this area, and the patient still presents with acute MI. Then for the ascending aorta, it extends up to the origin, just proximal to the origin of the brachiocephalic trunk, which is the first branch of the thoracic aorta. Then we have our left common carotid, and it ends distal, just about 1 centimeter distal to the origin of the left subclavian. Then beyond that, we have our descending aorta. So these are images of the patient. They did a CTPA, but regardless, we were able to pick up features of aortic dissection. So these are 2 different images, axial slices. We have an uncontrasted on my left, then a contrasted on my right, and we are at the level of the aortic arch. So for aortic dissection in an uncontrasted phase, we are interested at looking for any calcifications if they're present, because in cases of aortic dissection, the intimal flap, the calcifications will be displaced medially. So for this patient at this level, the only thing we were able to pick was this focal hyperdensity within the aortic lumen, and it was suggestive of internally displaced intimal flap, intimal calcification. Then looking at the contrasted image, we are still at the level of the aortic arch. We can still appreciate at this point where my cursor is, we can still appreciate the internally displaced intimal calcification. Then we are seeing the entry point, which was located at the aortic arch here. So here we have our true lumen, which is surrounded by the false lumen on either side. So this is where actually the tear happened, and it extended proximally up to the level of the aortic root, then also distally up to below the infrarenal portion of the abdominal aorta. So here, that's what we're able to appreciate. So we see this linear hypodensity, which is separating our aortic arch into 2 lumens. We have the true lumen, which is brighter because it's having active flow, so it enhances faster than the false lumen. Then this one we are cutting going down. So here we are at the level of the bifurcation of the main pulmonary artery. So we are seeing our ascending aorta here, then the descending thoracic aorta. And still we are able to appreciate the intimal flap with the double density within the aortic lumen. And we have our true lumen, which is surrounded by a larger false lumen. So the true lumen, when it's very large, it compresses on the false lumen, it compresses on the true lumen, and we can have a compromised flow to the peripheries. So in the descending aorta, still we are able to appreciate the true lumen, which is surrounded by the false lumen. Then here, we are at the level of the aortic root, still our axial view. We are able to appreciate this, the descending aorta having the 2 densities. Though here, what I wanted to show us is at the level of the sinus of Valsalva. We are seeing here this opacity, this linear hyperdensity. it's the left coronary artery coming out of the right aortic cusp. So, and we can see that our left coronary artery, it's coming off the brighter lumen of the aorta, so it's coming off the true lumen. So this patient would not present with any signs of MI since the origin of the coronary artery is spared. Then in these two images, we have a coronal view. I wanted us to appreciate, still we are able to see our true lumen here, which is surrounded on either side by the false lumen. And we see this hypodense linear structure, which is separating the two lumen. And when you follow down to the level of the aortic root, we see that there's actually extension down of the dissection up to the aortic root. And the aortic root measurement, it was measuring about 4.3 centimeters, which was increased, but it couldn't qualify it for an aneurysm. Then in this other image, I wanted to show us the extension of the dissection. This is our first branch of the aortic arch, which is a brachiocephalic trunk. And still we are able to appreciate a large true lumen, which is also bordered by this hypodensity, which is our false lumen. So that the dissection was actually extending cranially into the brachiocephalic trunk. Then in these other two images, we are at the level of the descending aorta now in coronal view. So we can appreciate still the false lumen, which has not yet enhanced, and our true lumen is enhanced, and there is actually significant compression of the true lumen at this point, which can actually explain the variation in the blood pressures that we were seeing. So the dissection continues, and also to note, the descending aorta, thoracic aorta was enlarged. It was also measuring about 4.5 centimeters. Still just evident for an ectus here. And it had this tortuous course. We see it crossing over from the left to the right, then back to the left side in the abdomen. So the dissection actually proceeded to involve the abdominal aorta. And in this axial slice, we are in the abdomen now, and we are at the level of the celiac trunk. So here, this structure I'm pointing at, sorry. How do I go back? So we are at the level of the celiac trunk, which is our first branch of the abdominal aorta. And I already said initially that we had some limitation. The opacification of the aorta wasn't really adequate. So at this point, when we were scrolling through, we could actually see that the density within the celiac trunk was less compared to the density within the aorta at that level. However, when you follow through the celiac trunk to its branches, that's the splenic artery and the common hepatic artery, it was actually lighting up just like the aorta. So we thought probably the celiac trunk is coming off the true lumen. Then we went down at the level of the superior mesenteric artery. At this point, it's a second branch of the abdominal aorta, and we see it's coming off. And the dissection actually extends proximally to the superior mesenteric artery. However, it was largely receiving its blood supply from the true lumen. And then at this point, we are at the level of the origin of the right renal artery. And we see our right renal artery here, it's clearly coming off the true lumen. At this point, still you can appreciate the false lumen, but it's really, really small now, but it's still actually present. So the dissection was still continuing inferiorly. So the right kidney, it's receiving its supply from the true lumen, so it's well perfused. Then for the left kidney here, at this point, we can appreciate that the dissection is extending as well to the left renal artery. However, most of its blood supply is from the true lumen. Then this was the point where the image actually ended, and we see the dissection still continues beyond this level of the Raynaud's. Unfortunately, it was a CTPA, and the acquisition was only done up to the level of the kidneys. Ideally, we are supposed to follow through until we find the entry point or where it ends. Sometimes it can go as far as the femoral arteries. So those were the findings for the patient. The report from the CTPA, we looked through, there were no evidence of any thrombus within the pulmonary arteries, and also the lung fields were generally normal. So in summary, we had a linear hypodensity, which is the intimal flap, which was creating a true and false lumen. And the entry point was at the aortic arch, extending proximally to the root and distally up to the infrarenal abdominal aorta. Then we had a dissection extending into the brachiocephalic trunk proximally, the proximal portion of the SMA, as well as the proximal portion of the left renal artery. However, our left coronary artery, the celiac trunk, and the right renal artery, they were rising from the true lumen. We couldn't visualize the right coronary artery in the images. Then there was generally ectasia of the thoracic aorta with a tortuous cause. So in conclusion, the findings were of Stanford type A aortic dissection. That was it for the patient. The next images are for a comparative case that we shall also look at to compare with this. Maybe if we have any question about the patient, we can first address that. Okay. So we shall continue. So I've just put a few comparative images. One, we shall go through a complete case of Stanford type A. Then we shall look at some images of Stanford type B, aortic dissection. So here, the image A, we see a Stanford type A. It involves the ascending aorta and the aortic arch, and it may or may not involve the descending aorta. However, for Stanford B, it's strictly confined to the descending aorta, meaning the dissection should start from a portion distal to the origin of the left subclavian artery. So we have here two images, CT aortogram at the level of the aortic arch. And for Stanford here, we see here we have our the proximal descending thoracic aorta, then the aortic arch. And we see the intimal flap, which is extending all the way to the aortic arch. So anything that goes beyond proximal to the origin of the left subclavian artery, it qualifies it to be a Stanford A. While in Stanford B, like we can see here, our linear hypodensity, the intimal flap, is really confined within the descending aorta. So here we had a case, a 50-year-old male who was presented with acute onset of severe chest pain, and they did a CT aortogram. And here what we are able to see, this was a well-optimized patient. We can see the aorta is really, really well opacified with the contrast. So at this level, we are at the bifurcation of the bronchus at the carina. So we are able to visualize the ascending aorta and the descending aorta. And we see the intimal flap within the ascending aorta, which is dividing the aortic lumen into the true lumen here, and superiorly then the false lumen. Then at the level of the descending aorta, still we are able to visualize our true lumen, which is well opacified, and the false lumen here, it looks hypodense. The false lumen can appear differently depending on whether there is flow within it. At this point, we see it's equally bright like the false lumen because there is active flow. Then here there is usually either stasis or thrombosis that will cause a delayed enhancement or actually no enhancement. So at the level of the aortic arch, still the same patient, we are able to appreciate the intimal flap separating the true and false lumen. So it's really similar to the patient that we had. Though here we see the celiac trunk clearly coming off from the false lumen, the smaller lumen. Then the SMA as well, it's coming off the true lumen. Then at this point, we can clearly tell, we see the left renal artery, it's coming off our true lumen, while on the left side here, we see the left renal artery, it's coming off the bigger false lumen. Then this dissection continued to the infrarenal portion of the aorta, as well as up to the left common iliac artery. So it's good that these images are acquired up to the femoral artery so that we are able to follow through up to the end where we can have the re-entry tear. So here still these sagittal views. I'm just trying to demonstrate for us for this patient. We see the intimal flap, which is causing the dissection at this level of the ascending aorta. And when you look down, the dissection actually continued, and we have a very small true lumen, which is supplying the abdominal organs. Then at the level of the descending aorta here, we are able to still appreciate the true lumen, which is well opacified. Then our minimally enhanced false lumen. That was for Stanford A. The patient, the findings were consistent with a Stanford type A dissection. Then for Stanford type B, we said the dissection is confined to the portion of the abdominal aorta, which is distal to the origin of the left subclavian artery. So at this point, we are able to appreciate the entry point here. This is our true lumen, then the false lumen, and we have this entry point. And at this point, we are able to clearly visualize the intimal flap separating the true lumen medially from the false lumen laterally. And also here in this sagittal view, we are able to still appreciate our true lumen, the intimal flap, and the false lumen. And to note in aortic dissection, since there is a tear with blood tracking behind the intima, the intimal calcifications will be displaced medially. And we can appreciate it here in this sagittal image. So for Stanford B, that is it. It starts from the portion that is distal to the origin of the left subclavian artery. Then the other thing I wanted us to take note of is how to differentiate the chronic aortic dissection, which has already thrombosed, from a thrombosed aortic aneurysm. So here we have two different images. One is aortic dissection, then the other one is a thrombosed aneurysm. And they ideally look the same, though there are nitty-gritty things that we look at to try to differentiate. So they are both a contrasted image, and we are at the level of the descending thoracic aorta. So we are seeing our lumen, which is well opacified. This is a aortic dissection. Then on this side, we have a thrombosed aneurysm. They are both thrombosed. So for the aortic dissection, like we said, we look at the calcification. In a dissection, they will be displaced medially because blood is tracking behind the intimal layer of the aorta. Whereas in an aneurysm, there is dilatation of all the three layers, the intima, the media, and the adventitia. So the thrombosis happens in front of the intima, so it will displace our intimal calcifications outwards. That's one of the features we can look at. However, in the absence of that, of the calcifications, it may be a little challenging to differentiate between a thrombosed aortic dissection from a thrombosed aortic aneurysm. Then the other thing that we can also use to differentiate, still here we have aortic dissection on my left, then a thrombosed aneurysm on my right. So the other thing that we can look at for a dissection, it goes on spiraling around the true lumen. So here we see the dissection and the intimal flap is present. Then we have the true lumen, and our false lumen keeps changing position as it goes down, like it winds around the true lumen. So we see it at this position, then it comes in front, then again it's posterior, then anterior. So that is how it keeps moving. Whereas in if we have a thrombosed aneurysm, the thrombosis will maintain its position in the posterior wall of the aortic lumen adjacent to the vertebral bodies. And as well here, we can appreciate the aneurysm, then we can also appreciate the externally displaced calcification. Then the other thing, we can look at the internal margins. In aortic dissection, we see a very nice, clean, and smooth margin, whereas in a thrombosis, we have these rugged, irregular margins internally. So those are some of the few things that we look at to differentiate a thrombosed aortic dissection from a thrombosed aneurysm. Yes, that's what we had from radiology.
Thank you very much, radiology team. So from the responses we have, I think nobody has a question for now. So at this point in time, I would like to invite our consultant, Dr. Msoke, to give us the medical management for aortic dissection. So Dr. Msoke, you're welcome.
Good afternoon, everyone. My volume is not good, but I hope you'll bear with me. I'm under the weather. Okay. That's how a white man says, under the weather. So I would like to welcome all of you to this grand round, but most especially the radiology department and also the cardiothoracic department. Dr. Habwe, you are welcome. And we also want to welcome everyone who is online, who has taken their time to come and attend this probably important talk. We are mainly going to focus on aortic dissection, but I'm going to just give you a preamble about aortic talk. Basically, what happens in the aorta. I'll just talk about aneurysms briefly, then I'll go into dissection. Because it's important for us to know when you are dealing with these patients, how do you identify them? How do you suspect them that this is a patient of possible aortic dissection? I hope it moves. Okay. So what do these three people have in common? This is not our talk of today. Albert Einstein, George and Lucille Bell. So Albert Einstein, you know him very well, passed on in 1955. Then George was a comedian, but also a producer in the USA. And then, of course, Lucille Ball was also a comedian and a movie actor in the USA, who died in 1989. So what do they have in common? That is what they had in common. All of them died from AAA. So AAA is abdominal aortic aneurysm. This is not our talk today, but that just to stimulate you that please go back and read about our aortic aneurysm in their entirety. From what we are going to talk about Stanford to AAAs, the risk factors and how they are managed. Just about the definitions, I remember the presenters we are talking about ectasis, aneurysm, normal. So what does that mean? So when we talk of an aneurysm or a true aneurysm, it is where you have a permanent localized dilatation of an artery, okay? So the dilatation should be more than 50% of the okay. So okay. So I think that is for better visibility. So an aneurysm, you have to have more than 50% increase in diameter from the original normal diameter. So basically have like 150% of your original vessel. Then in a pseudoaneurysm, it means you've had a disruption in the aortic vessel. So the vessel has ruptured and then the blood is contained in the tissue around the vessel. So that gives you what we call a pseudoaneurysm. Then ectasia. Ectasia means like your vessel is big or it has become bigger, but less than 150% of the original vessel or the original diameter. Then when we talk of arteriomegaly, it means diffuse arterial dilatation, okay, which involves many segments of the artery, usually greater than 50% from the original diameter. So it's very important for you to know when you're talking about these terms, ectasia, aneurysm, arteriomegaly, normal artery, what does it mean really? So this has already been talked about, but for us as cardiologists, we are mainly interested in the aortic root, what is there. So I don't know. Here, I think you can see, this is the left atrium. So blood coming from the lungs enters into the left atrium, then goes through these mitral valves to the left ventricle here. Then from the left ventricle is where you have your aortic valve. And then you have these 4 segments. Here, number 1 is the aortic annulus. Then the bulging is where you have your sinus of Valsalva. Dr. Keller has already talked about this. This is where the coronary arteries originate from. So usually it's bigger. So when the radiologist tells you that we measured the aortic root and they tell you the diameter is maybe 4.5, you have to ask them, where in the aortic root did you take your measurement? Did you take it at the annulus? Did you take it at the sinus of Valsalva? Did you take it at STJ junction or the sinotubular junction? Or did you take your measurement at the ascending aorta? It's very important for you to clarify where they took their measurement from, because all of them are different. This is basically like the normal kind of like ranges for the ascending aorta on CT. So for female, usually, and male, you want it to be below 4 centimeters, between 3.5 to almost 3.9. Then in your descending aorta, you want it to be less than 3 centimeters, both for male and female. So when you see them bigger than that, that means you are either having ectasia or you are having aneurysm. So what is the etiology of aortic aneurysms? It could be congenital, okay? So mainly we see it in Marfan syndrome, bicuspid aortic valve, coarctation. Okay, so Marfan's, we are going to look at it a bit in detail. Then Turner syndrome, you know Turner syndrome, webbed neck, short stature, delayed adolescence, and recurrent abortions. Noonan syndrome, this is of very importance to the pediatricians, but you can also see it in TGF-beta mutations, like in Ehlers-Danlos syndrome or Loeys-Diaz syndrome. So Loeys-Diaz is more like Marfan's, but they have a bifid uvula, and then they have hypertelorism, where their eyes are more wider. The distance between the two eyes tends to be wider. Then, of course, Ehlers-Danlos, we are going to look at a few features of that. So it's very important for you, when you find these congenital issues, these patients can come as adults, always to rule out aortic aneurysm in these particular patients. It can be degenerative, maybe mainly atherosclerosis, or it can be hemodynamic, like in hypertension, or it could be inflammatory, like giant cell arteritis, Takayasu's arteritis, Reiter's, Bessett's, Kawasaki's, ankylosing spondylosis or spondylitis. All these patients can actually have aortic valve, aortic aneurysms, or it can be infectious, like in TB, syphilis, HIV. So in our setting, mainly, we are looking at Marfan's, hypertension, inflammatory causes. We had a patient, I think, 2 weeks back at our mini round, I think had Takayasu's arteritis, but also infectious causes like HIV, syphilis, or TB. So in terms of diagnosis, of course, you take the history, the exam, the imaging, genetics diagnosis, you make a plan, and then, of course, you prognosticate and manage the patient and give them a lifelong care, because they're going to be under your care for a long time. So, of course, these are symptoms of aortic aneurysms. Majority of them are asymptomatic. So when you get a patient with a bicuspid aortic valve on echo, or if they come in with Marfanoid features, always look out for some of these symptoms. It has to be directed kind of like questioning. Chest pain or back pain, hoarseness, like my voice now, but mine is infectious. Call for dyspnea or stridor. Stridor usually comes because you can have compression of your recurrent laryngeal nerve, your left recurrent laryngeal nerve. And then, of course, the signs can be of those of distended neck vessels, especially if there is compression of the superior vena cava, aortic regurgitation, that is the murmur that you pick up on exam, fixed vocal cord paralysis, basically from compression of left recurrent laryngeal nerve. And you can have systemic features like embolism to the brain or to any other organ in the body. These are some of the features of Marfan syndrome. Here you have what we call the finger sign, whereby if you cross your thumb across this thumb and then you make a fist, this thumb will remain protruding. Okay, so all of you can do this on yourselves. And if you find a positive sign, then probably you need to go for screening. But always these patients have really very long arms and legs, okay? So when you take the height, the total height of their arms from one tip to the next tip here, if you measure that length, it's usually more than their total height. For example, here, it can be like 190 centimeters and the height is 180. So the ratio is usually more than 1, okay? So if you see a person with very long arms, always talk to them, okay? This is Ehlers-Danlos. I actually have a colleague of mine who has Ehlers-Danlos. So if you want to see Ehlers-Danlos, probably you can approach me. But they have hyperflexion and even hyperextension. So sometimes when you see on your TikTok, people who are doing funny things, they are very flexible. Always take note, they could actually be having Ehlers-Danlos syndrome. Their skin is more elastic, it can stretch, okay? And they really have very sensitive skin. So when you see these features, always look out for aortic aneurysms in this type of patients. So in terms of management, really, so what if you discover they have aortic aneurysms? So you can use medication to slow progression of the enlargement of the aorta. Beta blockers, SC inhibitors, ARBs, mainly losartan is what has been studied here. And of course, those who have undergone repair, especially AAA, you can give them statins to prevent recurrence. And Dr. Ahawa will talk about this, but of course you have to know the cutoffs when you send a patient for surgery when they have aortic aneurysm. If they are asymptomatic and their ascending aorta is more than 5.5, including those with a bicuspid aortic valve, send them for surgery. Dr. Ahawa will tell us which surgery they do on them. Mafani's patients is at risk of dissecting or rupture. So if their diameter is more than 4.5, you see their cutoff is less, send them for surgery. If they have a descending thoracic aorta of more than 6, the descending is the one that is going downwards. If it's bigger, more than 6 is a critical value for rupture, send them for surgery. Or if you monitor them every year and their rate is more than 0.5 increment per year, then send them for surgery. Or if you are going to do any surgery on the aortic valve and they have an aneurysmal aorta, send them for surgery if their diameter is more than 4.5. These are questions that SHOs can find somewhere. So I'm just going to briefly talk about acute aortic syndromes. Our focus today is aortic dissection, but there are others. We have aortic intramural hematoma, penetrating aortic ulcers. Many of these are precursors for aortic dissection. Usually that's how a dissection starts. There is a rupture in the vasa vasorum. You form an aortic intramural hematoma, then it can progress to aortic dissection. This has already been talked about. If the origin is before the left subclavian, that is Stanford A. If it is after the left subclavian, that is Stanford B. There is another classification called a DeBakey, where you have type 1, type 2, type 3, but more or less the same as Stanford. So in terms of natural history, remember, if you manage these patients medically, like the way this patient is being managed, 20% of them will be dead within 24 hours. This is Stanford A. I'm talking about now Stanford A. 30% of these patients will be dead within 2 days. 40% will be dead by day 7, and 50% will be dead by 1 month. So it means it is a very lethal diagnosis. When you make the diagnosis, that means the interventions have to be timely, and probably you have to send these patients for surgery as fast as possible. And even when they are repaired, their mortality remains high. Around 20% will die by day 30 from so many complications to the details right now. I've talked about this, how to make a diagnosis of aneurysm, but it's the same. making a diagnosis of aortic aneurysm dissection. Basically, take history, do an exam, and then do prompt imaging. So we know that 80% of these patients are going to come in with chest pain, or back pain, or abdominal pain, depending on where the dissection extends. 20% are going to get syncope, and this mainly comes from tamponade or pain. Some will come in with heart failure symptoms due to aortic regurgitation, stroke or limb ischemia, paraplegia because of intercostal arterial occlusion. So they can come in a very wide variety of presentation. So the imaging modality is mainly to confirm or refute the diagnosis and to determine if the proximal aorta is involved, that is type A, and then that means you have to do urgent surgery. And then, of course, identify anatomical features like pleural pericardial effusions, aortic regurgitation, and so many other things that you can pick up, like thrombus. So in cardiology, the preferred mode of investigation is an echocardiogram, but we prefer what we call a TEE, or a transesophageal echo, not a TTE. TTE is transthoracic echo. So here you go into the esophagus and you are close to the aorta. So you can look for the intimal flap, a dilated aorta. You can classify the true and false lumen by looking at color flow, and you can also pick up thrombus. You can also pick up aortic regurgitation, and this is a portable test. It can be done anywhere in the hospital. It is safe, it is accurate, it has a rapid diagnosis. It can even be used in the emergency room when the surgeons are operating. It can be used in ICU in very unstable patients. So it's really very handy. What about TTE? This is really very unreliable, as you could see in this patient. If it was only a TTE which was done initially, the diagnosis was most likely going to be missed. So, but of course, we are looking for the intimal flap, the dilatation. Like here, you can see that the ascending aorta is really dilated. Complications like AR and effusions, but it has a very low sensitivity, and you cannot visualize the ascending and descending aorta. So what this one means, if you suspect aortic dissection and you send your patient to a cardiologist and they tell you that echo is normal, it does not rule out aortic dissection. You have to go further and do more testing. So CT and MRI are the preferred modes of imaging. CT is fast and available. MRI avoids contrast and radiation and can also be used for follow-up. I'm not going to go into details of this. So which imaging test you choose, echo, CT, or MRI, really depends on availability, technical expertise, and of course what the patient has. But probably now you know how to decide. We know that CT and MRI sensitivity almost reaches 100%, and it also for the TEE. But you see that TTE, or transthoracic echo, only around 80% sensitive and only around 60% specific. So your normal echo is going to miss 40% of your patients when you order for a diagnosis of dissection. This is the treatment, and my last slide. Mainly you want to manage pain, okay, for patients who are coming in with dissection. And if they have hypertension, give them beta blockers, nitroprusside, SC inhibitors to lower their blood pressure. If they are normotensive, give them beta blockers to reduce contractility. Your target blood pressure is 110 in all the limbs, less than that. If they're hypotensive, that means they are losing blood, so you have to look for where they are losing blood, either tamponade or they're in heart failure. And remember, type A, aortic dissection, is an emergency requiring surgery. So I'm going to stop here and invite the next speaker. Thank you very much.
Thank you very much, Dr. Msoke. We're going to listen to the surgeon tell us what exactly they do for these patients.
Good afternoon, ladies and gentlemen. So my name is Dr. Ahabwe Kenneth. I'm a cardiac and vascular surgeon at Uganda Heart Institute, which is in 1C of Mulago. For those who don't know where it is. So, thank you, Dr. Msoke. Where is it? Dr. Msoke, for inviting me to participate in this grand round. We see quite a number of patients with aortic dissection. Most of these patients are referred to the Uganda Heart Institute. The expectation being that the solution is that in that place. So we have a bit of experience in them, and I'm happy to be here. So as we've already seen from previous speakers, aortic dissection is an emergency. It is both a medical and surgical emergency because both disciplines have a lot to do in the management. It is a fatal emergency. As we've already seen, the mortality is high. And we've seen the definitions, but surgically speaking, what we define as aortic dissection is when you can demonstrate presence of an intimal flap. Absence of that does not give us the definition for dissection. That is, as a surgeon, because it has implications on how we manage the condition. And we've already seen that you have two lumen, one true lumen and a false lumen. And usually the concern is that the false lumen will compress the true lumen, but also you might have vital organs taking off their blood supply from the false lumen, which is not good because flow in the false lumen is slow and sluggish. And most of the time is thrombosis. So you have a high risk for malperfusion of these vital organs. Now, down there I've written that it is a race between diagnosis and death. This patient who was presented was one of the lucky ones. She got chest pain and accessed a center that could make a diagnosis within 3 hours. What that means is that at least within those 3 hours, a decision to manage could be made. Medical management was initiated. And the most important thing in medical management is to control the blood pressure. We call it controlling the rate of change of blood pressure. We don't want swinging blood pressures. Yeah, we want a stable blood pressure at the target Dr. Musoke has said. That was a lucky patient. Now, a lot of our patients will have chest pain. They go somewhere, they're given ibuprofen, and they sent home. Or they'll go somewhere, they're treated as PUD. Okay? Now, by very few of those patients will reach Uganda Heart Institute. And that's why mortality is high. Some of them drop in their bathrooms, some of them drop in their homes, in their beds, they die. So the earlier you make the diagnosis, the better. So chest pain, as the first presenter showed us, chest pain is not MI. Chest pain is not PE. Chest pain can be a dissection. So you must make sure you have ruled it out before you declare someone an MI. If you declare someone an MI, what is the emergency treatment? Aspirin, high dose aspirin, loading dose, 300. Loading dose of clopidogrel, 300. What do you think that will do to a dissection? Okay, so not every chest pain is what? MI. For me, that would be my take home from this. So as surgeons, we work on the basis of a strong knowledge of anatomy. And the anatomy of the aorta has changed like any other thing. It gets updated. So some people came up with a classification system or description of the aorta, which they define as Ishimaru zones. Okay. So we have that red part is the aortic root. Dr. Musoka has given a description of it. Now, from there, from the ST junction, we start defining the aorta. Okay. So the ascending aorta is Ishimaru zone 0. Then you have the arch, which has 1 and 2, from the color code you're saying. The aortic mass is 3, and then you have 4, 5, and so all those, they have different implications, especially when it comes to description of the pathology, but also surgical management. And for the radiologist, yes, even description, because when she's describing the diagnosis, she's trying to make me understand how I'm going to manage. And I would rather she describe this way, these type of zones. Yeah. Histology is important in dissection. We've already said, by definition, dissection, you have a flap, an intimal flap, which means the flap, the intima, is separated from the media. Okay, I think that's clear. A number of classification systems have come up for dissections. There's the Bucky, there's Stanford. Now, the Bucky doesn't help us much as surgeons, so we don't talk about it a lot. We traditionally have been using the Stanford system, which says if you have a dissection extending anywhere from the arch, anywhere from the root to the end of the arch, that is Stanford A. And anything beyond or distal to the left subclavian artery is Stanford B. But 2024, a new classification system was described. Now, this classification system, again, is for surgeons because it combines a lot of things. It is called TEM classification. T is the type of Stanford you have. Is it A? Is it B? Is it non-A? Non-B? Now, from the descriptions you've had previously, from the previous speakers, you didn't see non-A and non-B. So this is Stanford A, which we said you have a dissection extending into either the root or ascending aorta. That is A. Now, you can have a dissection where you're seeing a flap only starting from the arch, not involving the ascending aorta, not involving the root. The management of that can be different. So that's why they have separated it from Stanford A. So that is described as Stanford non-A, non-B. Then Stanford B is what is clearly beyond the left subclavian. Now, that is the T in the term, T being the type of Stanford you have. The E is the entry point of the dissection, the point where the tear happened. So you can have an entry point in the arch and it extends retrograde into the ascending aorta and antegrade into the descending. Now, if I have a tear, the entry point in the ascending is different, surgically speaking, from an entry point that is in the arch. It's different from an entry point that is in the descending aorta. Yet both of them can give you a Stanford A because you can have extension retrograde. Then you have M, which is for malperfusion. You can have a dissection that is not affecting any vital organ. In other words, the brain is coming off the true lumen, the superior mesenteric artery, the celiac axis, the renal arteries are all coming off the true lumen. That is a good one. But you can have a dissection with a malperfusion. So you can imagine the urgency is different. So if you have a dissection and the brachycephalic artery is also dissected and the true lumen is compressed, you're worried about cerebral perfusion or right upper limb perfusion. So malperfusion has also been put into this classification. So why this is important is that it describes for you the type of patient you have, the urgency, and therefore what you need to do. Yeah. Pathophysiologically speaking, you have two things. Either you have wall weakness of the wall itself, or you have tension. Now, the common one is hypertension. It causes wall tension. But like what Dr. Musoka has described, you have other things that can cause weakness in the wall, those anomalies, those syndromes he was describing. The easier to manage here is wall tension, the hypertension. That we can manage. We can't change what happens in Marfan's, isn't it? So we look at it as modifiable and unmodifiable. What we can modify is what we're going to concentrate on medically. Now, she also pointed out the related syndromes to dissections. We have aneurysms, which I'm not going to talk about today. We have neurothrombus, which sometimes sections, and then you have penetrating atherosclerotic ulcer. We know that normally the atheroma is subendothelial, isn't it? Its build-up starts between that plane between the endothelium and the medial. But it can penetrate the endothelium and rupture into the lumen, and therefore create a point of weakness where you can have a point of dissection. But at first, you can just have an ulcer, which does not really qualify to be called a dissection. So this is an image of the neurothrombus. She gave us a good description of those. This is what happens in an atherosclerotic ulcer. Now, we've not had a lot of investigations in the description, but okay, we've had, sorry, the other one. But a chest X-ray was missed in the presentation. Now, we know that most of our patients are not in the center, are not in Kampala, where CT scans are all over. The patient will go to a health center where they can do a chest X-ray. As a clinician, you should be able to tell that a patient who has this severe tearing chest pain and has this X-ray, I don't know if it's clear, you should be able to have an idea and say, no, I don't stop this. I don't send this patient home with painkillers. Who can tell me what is pointing to a possible dissection or aneurysm? Anyone? No one? Hey, like this side. So the superior mediastinum is white, okay? Here, this. So for me, a patient who comes to me, severe tearing chest pain, white mediastinum, that's not an innocent chest X-ray, okay? This we've gone through already. This, for the radiologist, is important. We want, when we are getting measurements, we want measurements at all these points in blue. Because if, for example, we want to put a stent, we size the stent according to the measurements given here. So these are some of the patients we operated while I was in my training center in India. This was a Ugandan female who found us in that hospital. And you can see this patient has barely any true lumen, so small. This, majority of the rest is false lumen, but it was a Stanford A extending up to the femoral arteries. This was a different patient, an Indian patient, who had a contained rupture at the arch. So this was a pseudoaneurysm. This, at the aortic arch. Just a few examples. Echo, Dr. Msoka has talked about. So for us, a CT aortogram is the standard, the gold standard. And it is what we will ask for when a patient comes to us. And most of the time, we'll ask radiologists to give us a CD. We need that CD because, as you also know, you give more images on that CD than what you give on the films. So for purposes of surgical planning, we must have that CD and look at everything you have done. Yeah. Approach to management. The assumption is every Stanford A dissection is surgery, but the TEM classification further separates different patients according to the point of entry, according to presence of malperfusion. But generally speaking, Stanford A is surgical management. So what type of surgery is there is now the question. So a patient who has a Stanford A, in other words, the T is A. We said the T can be A, non-B, and B. So in this case, the T is A. So the next thing is, what is the entry point? So in patients where you cannot tell where the entry point is, so that is E0, you have the options of doing root, ascending, and arch replacement. Arch replacement, you can do total arch or hemi-arch. However, if I take it to the extreme where you see entry point at E2, what did we say E2 was? Are you with me? Have I lost this somewhere? So if you have the more distal to the entry point, the more difficult the surgery. So if you have a flap in the ascending aorta, that makes it type A. But the entry point is, for example, in E3, which is the descending aorta, it means you have, whichever surgery you have to do, you must cover that entry point. Because if you press the root and replace the ascending and the entry point is still not covered, you have not done anything. Are we together? Because the extension of the dissection is from the entry point. So the more distal, the more complicated. That's why you say in E2 and E3, if they are present, if the entry point is in E2 or E3, we do what we call a frozen elephant trunk. We shall see what that is. But the rest, you can replace the root, you can replace the ascending, you can replace the arch, you can debranch the arch, those 3 branches, you can cut them off and replace with grafts, or you can do what we call a frozen elephant trunk. I put this is from the same guidelines of 2024, just to show you that it is class 1 level recommendation. A patient who is type A is what? Surgical patient. And B, I'm not going to go into that yet. So what's the role of surgery? Why do we do surgery? One is to prevent them, because we saw mortality for these patients is high. We want to contain or repair rupture. One of the complications of the dissection is rupture. We want to restore flow in the true lumen. The true lumen is our main objective. Now, in cases where the false lumen is perfusing the vital organs, you must find a way of keeping flow into that false lumen. Because if you close it off, then those organs are going to undergo ischemia. In a way, surgery for dissection is palliative because we never really close the whole false lumen. You cannot. But you close off the inlet so that the false lumen thromboses and stops expanding and stops progressing. And then the next goal is to correct the regurgitation if it is present. Different types of procedures, but they depend on what level of entry the aortic dissection is. What are the general considerations? Of course, this is general anesthesia. You're going to make this patient sleep. These are patients you must do under continuous invasive monitoring. So you have an arterial lining, you have a CVP lining, you have cerebral oximetry on to monitor cerebral oxygenation. And then you also have CSF drainage monitoring to monitor pressures within the cerebrospinal fluid, that space, so the space. Why all that? Because dissection affects all these organs. Yeah. Then the access is median sternotomy. We open the sternum, we split the sternum, and you access the heart. Once you open the sternum, the next thing you see is going to be pericardium, right? You open the pericardium, you go to the heart, and you extend the opening until you can expose. Most of the time you'll be able to expose the heart, the ascending aorta, the innominate artery, the left subclavian. Sorry, the left common carotid. You will not see the left subclavian through a median sternotomy. So what we do sometimes is open supraclavicular to access the left subclavian artery. Now, this is where things become a little bit complicated. I'm going to try to simplify them. This is more like open heart surgery, but we are doing surgery on the aorta, right? The aorta is what carries all the systemic circulation. And yet it is what you're going to operate. So what happens to the systemic circulation? Okay? You're going to open the aorta, what happens then? How are the other organs getting blood? So this is where we employ cardiopulmonary bypass. So cardiopulmonary bypass is a whole different topic. But in simple terms, you're bypassing the heart and the lung. So you have a machine that drains the patient venous blood. It's drained from the patient by connecting a cannula on the superior vena cava and inferior vena cava. When you connect cannula to those two, you drain all the venous blood from the patient, send it to the bypass machine. The role of that machine is to oxygenate that blood, cool that blood, and apply whatever you need to apply, electrolytes, glucose, whatever you need to put. And then return it through the cannula that is going to connect to the aorta, and then you provide the systemic circulation. That is basic cardiopulmonary bypass. What it gives us is that you have a field that has no blood, therefore you can work, but also you are able to stop the heart and therefore be able to work. You cannot work, you cannot do this with the heart beating. That is number one. Now, if you look at that system I've just described, I'm still connecting a cannula to the aorta, but this aorta is what? Dissected. Okay? So that won't work. So how do I perfuse the system? What I've described is for basic heart surgery, open heart surgery. If I'm replacing a valve, I'll do that. But now I'm going to work on the aorta itself. So I have to find other ways of perfusing the system without using the aorta. Does it make sense? So what are the options? I can cannulate. The easiest one is cannulate the femoral artery. So if I put a cannula in the femoral artery and the blood that has been oxygenated, the machine returns and goes through the femoral artery, will have to go retrograde, because that is against its anatomical physiological flow, isn't it? Ideally, it is forward, but now I'm making it run backwards to retrogradely perfuse your vital organs. That is one option. Another option is me cannulating the axillary artery. The axillary artery through the innominate artery connects the arch, right? So if I put blood to flow through the axillary artery, it can go to the arch and then to the systemic circulation. In that way, I have prevented blood. I can be able to work on the root and the ascending. Are we together? Or I can use the left subclavian artery. I'll still be able to provide circulation to the system, right? So we divide those into central and peripheral cannulation strategies. Again, I feel like this is a lot for this congregation, but I cannot describe surgical management of dissection without you having a bit of understanding of this, because it's what forms how you're going to work. So they're different. All these are different arteries you can use to provide perfusion. So as you've seen, if I use femoral, that is retrograde. If I use the other arteries I've talked about, it is antegrade. So the debate is, do you use retrograde? Do you use antegrade? What are the benefits? What are the risks? The preferred is antegrade. Because if you have a dissection, and that complicates everything. Okay? So the other thing is, if my surgery, because all these explanations are like, if I cannulate the innominate artery or the right subclavian or axillary, I'm still hoping that I'm not going to do anything on the arch. But where I need to do something on the arch, I have no control. Because if I'm going to operate the arch, I cannot clamp it. If I don't clamp it, that means I'll have a lot of blood returning from the body. So what happens there? At that point, the only option is to freeze the patient's circulation. And that is what we call deep hypothermic circulatory arrest. We cool the patient up to 22 degrees, between 22 to 24. And at that temperature, there's no blood flow in the system. The blood doesn't move. That's why it is called circulatory arrest. You can achieve it at that level of temperature. But there are organs which undergo ischemia if you put the body under circulatory arrest. Organs that have a faster ischemia rate, especially the brain. So if I do deep circulatory arrest, I have to find out perfusing the brain selectively. I don't know if we're together. But in simple terms, I need to find a way of circulating the system. I need to find a way of working without blood affecting my working. So that is a lot to deal with. Yeah. So this is one of the patients we operated. This is the heart. This is the ascending aorta. Somewhere here is where the innominate starts from. This patient has had a dissection that was extending up to about here. If you look at that image very well, from the root down here up to somewhere around here, there's a bit of a bluish discoloration. I don't know if you can see. On the greater curvature, so the iota has greater curvature and lesser curvature. So around here, do you see this color? Is it the same as this here? No. So that's how we are able to tell externally that maybe my dissection what stops about here. Of course, the easier way is to put an ultrasound probe. Okay. Now, that is just one picture. So for that one, the arch was not involved, it was the root and ascending. So what we needed to do there is replace the aortic valve, the root, and the ascending. Okay? So the commonest procedure for that surgery is called the Bentel's operation. I'm sure you've had something called Bentel. Okay, for the MMed student. So what we do is you open, after you've gone on pump, you've done all those things I've talked about, and you usually have this picture. You see this clamp here, this is just telling you the limit. But also you clamp there and then you connect your cannula somewhere above to provide circulation to the system. So when you open, you will see two lumen. You have opened the false lumen, then the true lumen. You're able to see the one that is covered, that is still encircled by the intima. So in this case, we resect out the dissected part, replace the aortic valve. In this case, this patient, they didn't replace the valve, the valve was okay. So they replaced the ascending. So at the end of the day, you come up with something like this last picture here. So you will use PTFE grafts, and they are permanent, of course. They stay in your system. If the arch is extending, if the section goes into the arch, you have to know how to deal with the arch. Just if you have put here a few options, yeah, here. The easier one is to dissect a button that has all the three branches in this picture. Then we put a graft that replaces the aorta ascending up to the arch, and then implant this button, the graft, so that we end up with something like this. Are we seeing what I'm showing? So these are some of the patients we've operated. I hope I'm not scaring anyone. I'm assuming. First picture, we replace the root, the aortic valve, ascending, and all the arch branches. You can see the tube we put has three branches. All those three branches are corresponding to the different arch branches, okay? In the second picture, this patient's dissection was affecting the right coronary artery as well. So we replaced the root, replaced the arch, and then put a greater venous vein graft from here to the PDA, which is a branch of the right coronary artery, to provide flow to the area supplied by the RCA. So this is what we call an elephant trunk. By description, you know an elephant trunk? So this one replaces the root, the ascending, the arch, and then you drop a stent. That graft has a stent that is dropped into the descending aorta. In the case you have an inlet, the E2, E3. Okay, I think I want to stop here. I'm sorry, I can't make it simpler. I have tried. Thank you.
Thank you very much, Dr. Kenneth. So at this point in time, I don't expect any questions because from the way how the audience was, you seemed like you understood everything. But the take-home message, I think there's so many things that we've learned today, but don't forget, not all chest pain is MI. So you should think of other things like aortic dissection. And I would like to invite the grand round coordinator at this point in time, because since this is our last grand round for the semester and for the year, I would like to invite her to have some communication before we can get to listen to the head of department who is online. Thank you very much, Dr. Reed.
Let's give the cardiology team another round of applause. Cardiology team, we thank you for this wonderful grand round. And at this point, I would like to thank everyone that has been part of this journey. This was our last grand round for this. This was our last grand round for this academic year, and it therefore marks the end of my term as coordinator. And at this point, I would like to welcome Dr. Nambago Simon, introduce him to you as your new coordinator in the coming academic year. It was a pleasure working with all of you. Thank you.
Yes, good evening, everyone. Yeah, my name is Nambago Simon, and I'm an SH of internal medicine.